nothing. Here's your ninepence. I'm not dead. There. He says he's not dead. Yes, he is. I'm not.
So Shockwave is not dead, and no, he won't be dead soon. This is the best sound. What can be better than this? Just sitting there, listening to the stone breaking up, checking your emails, checking your stocks. Shockwave will never die. Why won't it die? It won't die because patients want it. Urologists want it. If you ever go to a conference and ask urologists what would they do if they had a 6mm stone in the kidney, no one picks ureteroscopy. Everyone raises their hand for Shockwave. Similarly, when we ask patients, if you had an 8mm lower pole stone, what would you do? Shockwave, oh, it doesn't work so well. It only works in 2 out of 3 people. A scope, laser, 90% success. Nobody wants that. Nobody wants the scope going in through the you-know-where, going up to the kidney, having a stent, having pain for a week. Everybody would prefer something less invasive, less painful. Are they right? Are patients right? They are. If one looks at the risk of having to come back to the ER within 30 days, 11% with ureteroscopy, only 7.5% with Shockwave. And we'll talk a little bit about what that 7.5% is, when it happens, why it happens, and what you could perhaps do to decrease the risk of coming back to the ED. Randomized clinical trials that have compared Shockwave to ureteroscopy ask the question, would you do it again? 90% of Shockwave patients say yes, even though the stone-free rate was only 35%, whereas only 63% of patients who had ureteroscopy would raise their hand and do that again. So if Shockwave is here, if it's not dead, how do we keep it around? What do we need to survive? Better patient selection, better technology, and some of that Dr. Patel will be talking about in the next talk, and improved technique. So for patient selection, I think you're all aware of the NIH study looking at ultrasound versus CT for diagnosing stones in the ER. And one of those pragmatic studies, meaning that they didn't really look at questions that we want to answer. So the unfortunate thing about ultrasound is it's very inaccurate. It's inaccurate to tell us if there's a stone. It's inaccurate to tell us what the size of the stone is, which really directs the forms of therapy that we can offer a patient. And it allows us to counsel the patient on what's the likelihood of stone passage or success with different procedures. So can ultrasound tell us the stone size, the location, stone density, skin to stone density? Can it reliably tell us is there a ureteral stone? Can it show us the lower pole anatomy, and can it give us a sense of whether the stone is impacted? All the answers are no. And all these questions can impact the decision on whether to wait and see if the stone will pass, try Shockwave, try ureteroscopy, or try PCNL. So this was a study from Cleveland that we did where we looked at patients who'd had a CT and an ultrasound within 4 weeks of each other. We considered the CT to be the gold standard, and if the CT said there was a small stone, the chance that the ultrasound said there was a large stone was 31%. So a third of the time, the patient really didn't need anything, but the ultrasound got them worried that, oh no, I've got a big stone, I got to do something quickly. Let's call Dr. Humphreys, I need to see him within the next few days because something bad is going to happen. In contrast, if the CT showed a large stone, a 10mm stone, 19% of the time, the ultrasound said there was no stone. So we're falsely reassuring patients that they don't have any stones when indeed they might have something very dangerous lurking. They call you 5 days later, you told me I didn't have a stone, why am I in the ER? So if we're not able to identify stones, if we're not able to clearly tell what the size of stone is, then we've lost the most important thing that stratifies our approach to the stone patient. And the CT provides other information. The Hounsfield units, or the density of the stone, and the skin to stone distance, both of which combined can predict with 90% certainty that Shockwave will work, or with 40% certainty that it won't work. So these are important tools to help guide us as to whether Shockwave is a good option or not for that patient. So this would be an example of a proximal ureteral stone. The Hounsfield units are 100, and the skin to stone distance was 10 millimeters. We did shockwave. After 2,000 shocks, the stone is gone. Now, guidelines would tell us that success rate is better with ureteroscopy than with shockwave. It's always going to be better. But p-values don't matter to patients. Pain matters to patients. And they will still prefer to choose this type of modality even if the success isn't quite as good. A lot of numbers, people use 10, people use 9, I use 12. So the rule of 12s would be if the stone density is less than 1,200, if the skin to stone distance is less than 12 centimeters, and if the stone size is less than 12 centimeters, and if the stone size is less than 12 millimeters, and if the stone is not in the lower pole, this would be the ideal patient to recommend shockwave as opposed to ureteroscopy. As one of these becomes unfavorable, it doesn't mean that we can't offer shockwave, but we have to counsel the patient the chance of success goes down. So I typically say the best you can get with shockwave is about 75%. That might go down to 60% if one of these parameters is bad, might go down to 40% if two of them are bad. And beyond that, I'll say, shockwave probably isn't the best choice for you. It's probably better to try an endoscopic procedure. I mentioned looking at impaction. This was from Dr. Gupta at Mount Sinai, where he took patients where a stone failed to progress over 2 months, or they tried to put contrast or a wire past the stone and it wouldn't go, or endoscopically they could see that the stone was really stuck. And then they looked back retrospectively at the CT scans and found that if you measured the Hounsfield units underneath the stone, if this number was 27 or higher, there was an 85% chance that the stone was impacted. And if one knows the stone's impacted, then maybe that patient in the ER, we won't say go home and come back in 4 weeks if you don't pass the stone. That might be the patient that we recommend early intervention as opposed to a trial of observation. That might be the patient where we say, well, maybe shockwave is not going to work as well because you have impaction and edema. Maybe that's the patient that we need to do ureteroscopy. Or that might be the patient that we say, you don't even need ureteroscopy, you need a stent to open things up, to get you decompressed, to stretch the ureter, because we're going to have a higher chance of failure with ureteroscopy because your stone's impacted. So in terms of improved technique, first thing is making sure there's good coupling. Dornier now has a machine where you can use a camera on the inside of the plenum to monitor for air pockets. And by smoothing out the air pockets, you can decrease the chance that the stone won't fragment because there will be better transmission of the energy. Or even better, I prefer to use a device that doesn't rely on gel, but rather relies on water. So the Storz machines couple through water as opposed to gel and improves the fragmentation rate by improving the transmission of the energy. And this just shows how spreading with your hand increases the amount of air. So if you are using a gel-based treatment, place the gel on the plenum and then raise the plenum onto the patient to decrease the amount of air that there is between the patient and the treatment head. Using general anesthesia is helpful, decreases patient motion, it allows you to control the ventilation a bit more, and improves overall stone-free rates. And then going slower is better, and going at low energies is better. Better in terms of fragmentation, but also decreases the risk of a hematoma or parenchymal damage. Pausing after the first 100 shocks to allow the sympathetics to kick in and vasoconstrict the renal artery will decrease the risk of hematoma or other hemorrhagic complications. And then, as I mentioned, treating slower is better, in particular for stones that are larger. For smaller stones, perhaps the rate isn't as important, but either 60 or 90 is good. Both of them are better than 120. And so I often will like to treat with a gated fashion. That way we can avoid arrhythmias, but also reach a target of about 80 shocks per minute. So to summarize, in terms of technique, general anesthesia, coupling, voltage stepping, 3-minute pause, and slower is better. Medical expulsive therapy, we use alpha blockers for a week before and a week after shockwave to improve the chance of stone passage. We don't place a stent. If you think you need a stent, then you probably need a scope. So stents will increase the chance that the patient will need to go to the ER. Stents will increase the chance that patients will need a second procedure. So really, shockwave should be done without a stent. That's one of the main reasons that patients choose it. If you decide to place a stent and do shockwave, then perhaps a ureteroscopy would have been a better approach. Dr. Chu and Dr. Pace have looked at shockwave for ureteral stones, and this is an area where I think perhaps we can revisit. Dr. Chu in particular is focused on distal ureteral stones, and Dr. Patel may be commenting a little bit about this in the next talk when we talk about some of the new technologies with shockwave. But one of the big things here is don't do shock, shock, shock. If the first shock doesn't work, at most maybe you could try it one more time. If you do it one more time, you can improve the success rate by about 8%. So typically I'll try a second shockwave only if the stone has gone from 10 millimeters to 6 millimeters, something like that, where I know at least the stone has responded in some degree. If it doesn't respond at all, then I don't offer a second shockwave. In contrast, one sees that further retreatments really doesn't give any advantage, and so it's better to proceed to an endoscopic technique. Patients come back for a variety of reasons, usually because of obstruction, pain, nausea, vomiting, but 20% come back because of some infectious types of complications. The AUA guidelines initially said to give one dose of antibiotics, then it was revised fairly soon after and said don't give antibiotics. But I think one can tailor it, so if the patient has a risk for either from prior UTIs, risk of struvite, other considerations, indwelling stents or Foleys, those would be reasons to consider some antibiotics. And then this just alludes to Dr. Chu's studies, which shows fairly good success with distal ureteral stones with shockwave lithotripsy. So to summarize, shockwave is not dead, it's alive and it's going to stay alive. And with that, we'll hear from Dr. Roshan Patel from UC Irvine about some of the new technology that's going to help it stay around. Thank you.